guys, happy lab week. Today I wanted to do a video. I haven't done a video in quite a few months, but I wanted to title this video Ask a Scientist and questions that people may have about the lab. Now, whether this be people not in healthcare, people in healthcare, nurses, etc. So I did go around the clinic that I work at and asked a few people what kind of questions they had about the lab. So I did make a little cheat sheet so I can kind of remind myself what questions I want to ask. But let's see. Okay, first question I had is, what's a MedTech? So some people do get confused when talking about a MedTech. They think it's a medication technician, which I guess, could be short for that as well. But it's a medical technologist. And now the term is actually medical laboratory scientist. So when MedTechs or medical technologists first came about, they were called medical technologists. And then I think for a short amount of time, they were also known as clinical laboratory scientists, and then that kind of merged into the medical laboratory scientist, which is what degree I have and what the degrees are known as today, at least in the United States. Elsewhere, they may be called something else. Another thing I wanted to talk about is kind of the hierarchy in the lab. So there's a lot of different jobs that you can have and work in a laboratory. There's bench technicians, there's like processors in some labs, depending on how big the lab is, that to process the specimens. Where I work, we have phlebotomists. They're also called health technicians. And what I kind of compare the phlebotomist or health technician to would be like a CNA, where they do have certification, but actually some phlebotomists don't have to have certification. They may get training on the job, and which I'll talk about that in a little bit. But then there's also MLTs. So MLTs go through a 2-year program, and then MLS, which is what I went through, is a 4-year program. So, and then your internship. So it's basically like 5 years. Some people can do it in 4 years, but everybody's route to going to the lab is different. Some people start out as phlebotomists, work their way up. Some people, their whole life, I guess, is a phlebotomist, and some people, may work their way up to lab manager. It just depends. Another question we had is, what's your degree and how long did it take? So I have a 4-year bachelor's, and my degree is actually in biology, specifically like microbiology, cellular and molecular biotechnology. That's my college, that's the degree I got it in. And with that degree, I could do other types of jobs. Now, there is specifically a medical technology program at some colleges, which I did not do that. I got my 4-year degree and then went and did my internship and then did my boards and became a medical laboratory scientist. So, some medical, I always want to call them medical technologists, because it's kind of what we refer to ourselves as, even though that's like the old terminology. So I know some med techs that even have their masters, and I even know in MLT, although it's just a 2-year degree, she actually did get her bachelor's, but she didn't know about the medical technology program, so she actually went to an MLT program when she could have went to an MLS program. So her counselor just didn't know about it and didn't know that that was an option once she graduated. So, and like I said earlier, some phlebotomists, some are certified and some do training on the job. So it really just depends. Some places require you to be certified and some don't. So another question we might get from someone is, why are you taking so much blood? So a lot of it depends on how many tests your doctor ordered. Another reason why we could take a lot of blood is if it's in-house testing versus send-out testing. So because I work at a clinic, we do a fewer amount of tests than a hospital would versus somewhere like Quest or LabCorp would. So it kind of depends on where the tests are going. I know like LabCorp and Quest, they require a greater volume for testing than we would just need in-house. And then if there's a lot of like, immunology testing, serology, virology, those kind of tests, they just require more than a regular just chemistry panel would, or hematology, a CBC. So, another question is like, why can't you get it all out of one tube? Different tests require different stabilizers in the tube. So some tests need your blood to clot, some tests don't need your blood to clot at all, like a CBC, because if your blood clots, then your platelets are used up in the clot, and we need to know with that test how many platelets you have. So another thing is when people say, you're going to take all my blood, well, so most of the time tubes are about 5 milliliters of blood. They can be 10 mils depending on the type of tube. But if they're about 5 mil tubes, and your body has about 4,500 milliliters to 5,700 milliliters of blood, that's like the average person. So if you're getting blood taken, then that's only about 0.1%, like one tube is about 0.1% of the amount of blood you have, which is like 0.001. So really it's not that much blood. Another question is, what does hemolysis mean? Why does it happen? Etc., etc. So we always make jokes that our centrifuge, we call it, a lot of people have call it the hemolyzer 5000 or whatever. The centrifuge, when you're spinning the blood, that's not going to cause lysis of cells. They're kind of already lysed or not lysed due to many factors, reasons. But so one of the reasons your blood can be hemolyzed is you can actually be hemolyzing your blood internally, which would be like a hemolytic type of anemia. So that can be due to your spleen. So your spleen kind of takes out your red blood cells that it doesn't like. So a lot of times when people have a splenectomy or have their spleen taken out, their blood will look different than other people's because it kind of takes out the fragments of red blood cells and the ones that are misshapen. So if you don't have a spleen, that doesn't happen, and you'll see that more in your blood smear when we look at your slide. Another reason can be bacteria. So it can actually cause you to hemolyze your blood, like like how the bacteria works. It can just, lyse your red cells, which is obviously not good. And then also another reason can be a transfusion reaction. So say you may have some type of antibodies to a certain type of blood. And if you get transfused with that, which hopefully you would get, your blood work done ahead of time, so you would know that, you're not going to react. But some people, no matter what type of blood they get, even if they've been cross-matched and everything's bad every time, I guess, that there's going to be some type of transfusion reaction regardless. And that really stinks because you're going to have a low amount of blood, and it's going to possibly make it lower if you have a transfusion reaction that's bad enough. But anyway, so another reason you can have hemolyzed blood is due to improper draw. So if the tourniquet's on too long, if you pull on the syringe too hard, that vacuum can really lyse your red cells. Same if you're using a syringe, when you're putting it into the tubes, then if you push too hard, that can lyse it as well, because it's pushing it in the syringe vacuum, and then that tube automatically has a vacuum as well, and so then it can lyse it then. But I also put down milking a vein. So if you're really trying to, like, I've had people draw my blood and they're like squishing my vein. I'm like, that's not gonna be good. And then as another thing I've not seen so much of, but if you're like pumping your hand like this, that can cause hemolysis. I think way back in the day they used to say to pump to help your vein pump up, but most of the time that's not necessary. That doesn't really help, and it can just cause, same as when you have a tourniquet on too long, it can cause your potassium to increase because of that muscle constriction. So, and then another reason, I guess kind of like the last group of reasons, is if the patient is a hard draw. Sometimes things can't be avoided if hemolysis, if you're trying to draw out of really small veins, if the vein is very fragile and the vein blows, a lot of times then your blood's going to be hemolyzed then. If it's a hand draw, sometimes those are just hard as well. If you have to go to the hand more often than not, it's not going to be super great. Some people have awesome veins. It really just depends on the case-by-case, patient-to-patient basis. And the last thing I want to say is if you're getting a small volume of blood, so say you have, your 5 ml tubes, and say you don't even get a mil in there, the vacuum from the tube, because that's so small of a volume, it can hemolyze it. So even though it may not have been that hemolyzed to begin with that vacuum of the tube, when you put the blood in there, it can really shred those red cells and make the serum or plasma hemolyzed. Okay, so another question that I get is the difference between a UA, also known as urinalysis, a drug screen, and urine STD testing. So on some of my videos, I'll have people ask about drug screens, but they're really just getting a urinalysis, and sometimes those can go together, but I'll get to that. So urinalysis. So if you're just talking about a UA, that's what we call it for short. Urinalysis with microscopy. It's just testing to see if you basically have a urinary tract infection. That's the main reason people will test for urinalysis. Now you can also find out other things from your UA. You can see if you have protein in your urine, glucose, like if you have diabetes, the protein, if you have like kidney issues, so although its main job is to find if you have a urinary tract infection, you can also find out a lot of other stuff from just a urinalysis, especially if it has microscopy with it. So some places automatically do a microscopy on every UA with microscopy that's ordered, and some other places they only do the microscopy if it's indicated based on the urinalysis part. Like if the white blood cells are present, or red blood cells, or bacteria, nitrates are positive, then we're going to look at it under the microscope. So that's the microscopy part. But some places, if everything's negative, everything looks clear, then they won't do the microscopy. So it really just depends. But with the microscopy part, you can see casts. So usually if you have protein, you could have some casts in your urine, and that's made by the kidneys. You can also have crystals in your urine, which is from kidney stones. So that's important, definitely, if you're getting a UA, and you'll probably want a microscopy with it if you think you have kidney stones, and that's one way to see if they're in there or not. You also probably have blood and protein in your urine, just in the dipstick part, but those crystals are very important in deciding if it's a kidney infection or a urinary tract infection, or it's actually kidney stones. Another thing is trichomonas. So trichomonas is my favorite parasite / STD. I know it's a weird thing to say, but they're my favorite to find under the scope. They like move around, and they have a flagella, and they're cool. Okay, so that you would see under a microscope as well. Now you wouldn't know that if you didn't look at the microscope part or didn't have that one. Drug screen. So there can be pre-employment, so before you start a job, if you're on the job and they suspect something, that'd be a random one. Some people need drug screens to refill certain types of medication, especially like pain medication. Psychiatric evaluations, if they need to figure out maybe if you took certain things, certain substances. And then with drug screen, there's anywhere from like a 5-panel to a 12-panel. So there's a really wide range of the number of types of drugs that they test for on a drug screen. And then with STD testing, you can get like STD trichomonas. You can get that tested. Now that you can see under the microscope, or there's also a swab test that you can get done, and that's done by PCR usually. So there's ways that you can get it done from a urine and not from a urine. Same with like gonorrhea and chlamydia. You can get that tested from a urine, or it can also be a swab test. So some people ask, can they run a drug screen off of your urinalysis? They could. We would have to get an order for that to run it, but UAs inherently aren't for drug screens. So, another question is, why can some tests be done by a finger poke, and why do some of them have to be drawn from a vein? So with the finger poke test, that's mostly like bedside glucoses. Some places do their coagulation test from a finger poke. I worked at a clinic where we did those. And also if someone comes in and they're unconscious, they'll do that right away to see if maybe they're bleeding out or something like that, if they're clotting. Then we'll just do a little bedside coag test, as that's just part of the deal. Another one is, especially on kids, they'll do like lead testing, heavy metals, and that'll be like with a finger poke. So those are kind of a few of the ones that are just finger pokes. Now on babies, they have the heel test. That's for the PKU. It stands for phenylketonuria, something like that. It's basically aspartame. It's called a PKU because of that specific test, but really it tests for a lot of disorders like congenital heart defects, and I think there's even like a thyroid on there, and there's a bunch of different ones, but we call them PKUs even though there's more than that on that test. But the PKU one, they found out that certain genetic defects, so you can't break down aspartame or like fake sugar, and it can cause a lot of issues. So that, along with the other, they get done by a heel poke. And then veins, so that's just basically all your other tests are mostly done by that. So the instrument run coagulation test is done from a vein draw, not just like the little handheld guys. We have a big, analyzer that runs those, and those need to be done from a vein. So, okay, answered pretty much that, hopefully. Another question is the difference between stat labs, routine labs, and ASAP labs. So, a stat lab, we usually try to get done within an hour. I think probably different hospitals have different rules, but stats, we want to pretty much get them done within an hour. It's kind of important, they're saying like, put this as a priority versus your other work. ASAP is within 2 hours where I work, and then routine is 8 hours. So most of the stuff, since I work at a clinic, is considered routine, but we do get a few stats or ASAPs every once in a while that they would like us to, get done as fast as we can, which we try to get everything done as fast as we can regardless. But if you're asking about how long specific tests take, it really depends. Are you talking about just the instrument or the whole process? How long does it take for the blood to get drawn? How long does it need to sit before it gets centrifuged? Our serum type tests that need to clot first, that can take up to like 30 minutes before you centrifuge it. Any of our plasma tests, they don't have to clot, they shouldn't clot, and so those won't take as long. You can just centrifuge it right away, or if you have like a CBC, we don't centrifuge those at all. We just need to have those rock for a little bit before we put them on, and so that doesn't have as long as turnaround time. Except for a few examples, except for a few exceptions. With CBCs, a lot of those have a differential, and so sometimes we can go with the differential the analyzer gives us, and sometimes it will give us a flag and say, hey, you guys need to look at this under the microscope, there's something not right here. And so with those, it's going to take a lot longer because we are going to have to manually make a slide, and we're going to have to look at that under the microscope. So it's not just an analyzer runs it and it's done. It's going to have to involve a little more work, but it's something that's very important that we might find something in there. It could be some type of blood cancer that they haven't been diagnosed with, or they're monitoring to see how they're doing. And so that's important that we do that. But in that instance, it's going to take, a little bit longer than the, 5 minutes it maybe takes to run a normal CBC on the analyzer and, turn it out. It's not very long. Chemistries, I think they take about 15 minutes. Some chemistry tests take longer, so it really depends if you just have a complete metabolic panel or if you also have a lipid, or if a test is critical and we need to rerun it before we turn it out. So every instance is different. Let's see. Another thing that we like to do is on stat testing. Sometimes we'll ask our phlebotomist, and if it's later in the day, we'll ask them to get a green. So a green top tube has plasma versus a red top tube has serum. Serum, we have to wait 30 minutes to clot. With a green top tube is plasma, we don't have to wait for it to clot. And so those we can put right in the centrifuge. So that speeds up, makes things already 30 minutes faster. So that way we can get that stat turned out even quicker than if it were a red top tube. Let's see. Oh, the difference between plasma and serum. I think that's the last question I have, right? Yeah. Okay, so the difference between plasma and serum, like I talked about, serum has to clot, okay? And plasma doesn't. So serum has all of those clotting factors in the clot. Now, there's serum separator tubes, and that's where you've seen, well, maybe you haven't, but there's gel, and that separates the serum from the clot, and that, it keeps the clot off, or it keeps the serum off of the cells, so things aren't mixing up and all that. Now, there's some tubes that don't have that serum separator, and there's some testing that you actually don't want to be a gel tube, because like certain drugs, it could get caught up in that gel, and so they don't want that. But plasma tubes still have all those coagulation factors in there. So when we're testing coagulation tests, we don't want it to clot, and so we want to test those factors. So those get spun down. Those are sodium citrate tubes. And then plasma, the green top tubes, those still have the factors in there. And a lot of chemistry testing, it doesn't matter if it's plasma or serum. But with coagulation tests, it has to be plasma, and with CBCs or complete blood cell counts, because we're testing the platelets, we need to know that's part of the coagulation factors. That's part of what makes clots, the platelets. So we need to know those. So I think that's it. What I want you guys to do, if you've made it this far, and I'll also put it in the description box below, but if you have any lab questions, I would really like to make this a series. I could answer questions literally all day and not be done with questions people may have. So if you have any questions you can think of, comment down below and I will make a second video. But happy lab week to everyone. I know it's also medical assistant week, and I think it's also psychology week. So happy weeks to those people as well. Stay safe out there, and I will see you guys later. Bye.